As national authorities authorize and recommend a third shot for kids 12 and older, author and reporter David Zweig conducted a deep dive into the data around boosters for children. According to Zweig, America is an outlier when it comes to its vaccine policy for young people, as some countries don't require vaccinations for children at all or consider natural immunity the equivalent to one jab. Just last week, the World Health Organization's chief scientist said there is no evidence that healthy children or healthy adolescents need boosters.
And while many countries are taking a more cautious route with kids, the CDC and FDA are still going full steam ahead. Last week, Dr. Fauci discussed when Pfizer will be ready to release vaccines for children 4 and under.
And the original data that was put forth, it looked like the dose and the regimen for the children who were 6 months to 24 months worked well. But it turned out that the other dose, namely the other group from 24 months to 4 years, did not yet reach the level of non-inferiority. So the studies are continued. It looks like it will be a 3-dose regimen.
Fauci noted that there is no set date for Pfizer as they continue to bring data to the FDA on the studies.
Joining us now to unpack all of this is author of Invisibles and writer David Zweig. We're also joined by sociology professor at the University of Colorado, Denver, and author of Calling the Shots, Why Parents Reject Vaccines, Jennifer Reich. Thank you both for being here. So David, talk to us about, this. You wrote a post for Barry Weiss's Substack last week that I quite enjoyed. And, you were pointing out that we're really an outlier in how we're dealing with childhood vaccination and childhood boosting compared to other countries, compared to other health authorities. What is motivating or what is, driving our CDC's decision making that's so different from everyone else?
That is a very good question. It's hard to say, what their motivations are. All I can do is report on what is happening and report on the sort of decision-making process at play. I was able to interview one of the members of the CDC's advisory committee in a really lengthy and surprisingly candid interview to get kind of a window into how did they come up with a policy that, as you noted, is so different from many other countries around the world. Yeah,
and what are they? They're just not looking at the same because we've seen, we thankfully throughout the course of the pandemic, the lower risk to children and and if there's much lower risk of the disease itself to children, then the trade-offs or the risks of getting the vaccine, which are very slight. But if the disease has a slight risk or much reduced risk anyway, then even a slight risk of some negative outcome with the vaccine matters more.
You're exactly right. The cost benefit, this is a really high bar to clear. I think in your clip with Fauci talking about the younger kids, when the incidence of severe illness is so rare already amongst some kids, amongst almost all kids, that in order for the vaccine to be worthwhile for them, at least on an individual basis, the effectiveness bar needs to be incredibly high. And it's challenging to meet that when you weigh that against the risks. Even though they are very small, it's not zero, the risk. And what I found in my investigation, even in the meeting itself, the evidence presented by the CDC itself showed a negative cost benefit for young males, that there was a higher incidence of myocarditis per 100,000 doses than there was per 100,000 people getting hospitalized from COVID. And this is not conspiratorial stuff. This is in the meeting itself. This data was presented.
So interestingly, countries like Sweden, for example, just announced last week that they are not even recommending vaccine doses at all. Not 1, not 2, definitely not 3 for kids under the age of 12. So what was the reasoning when you did your interview, when you discussed what was their reasoning for going ahead and authorizing a booster for kids?
Yeah, so this was really surprising. And I spoke with a number of other experts who were kind of shocked when they found out that part of the reason, and I don't think a lot of parents are aware of this, a prime reason for the CDC's recommendation of boosters for kids is not to prevent severe illness. It's to prevent merely mild symptomatic infection. And as noted by this member of the advisory committee, not only was part of the reason just to prevent mild infection, but she readily admitted this is likely to only be beneficial for around 2 months before the antibody boost begins to wane. So we need to really, really be clear about this to parents so they understand when they are having their child injected for a third time. And by the way, that may be a really wise idea for certain children. But for other people who may have a child who's already had natural infection, you may have a son where their risk is higher for myocarditis, that the benefit is not primarily to prevent severe illness. The benefit is merely to prevent mild or even asymptomatic disease for a span of around 2 months before the antibodies wane. I don't think this has been accurately or clearly conveyed to the American people that this was a prime justification for the recommendation of boosters.
And Jennifer, what's your read on why the United States has handled this differently than other countries?
I think we've handled the vaccine since the very beginning differently than most countries. And we're weighing, I think, a much more diverse population. We have a lot more questions about how our healthcare system is going to serve people that a lot of other countries are better equipped to deal with. There's a lot of variables in the mix here. I think when it comes to vaccinating children, we always have a tension between, balancing risk and benefit. But vaccines are not just a technology for personal benefit. And we have to sort of think about what that means. So in one way, the risk to children, most children have mild infection, which is true, but we are closing on 1,000 children who have died of COVID and, 6,000, 7,000 who've been hospitalized post-infection, who had maybe asymptomatic cases and are being hospitalized for multi-system organ failure under this MISC. And those are considerations too. Those are small numbers compared to adults when we're closing in on 1 million adult deaths. They're not even comparable. But children generally they're not typically hospitalized and they generally don't die. And so this is still one of the top 10 causes of death for children. And that's worth considering. And we'll say it's not equally distributed against all children or across all populations. So we know that of the children who have been hospitalized, they're more likely to be children of color, and they're more likely to have other kinds of health conditions. And that's a consideration too when we think about different kinds of strategies when it comes to vaccination.
Well, I think that's a great point, Jennifer, but it speaks to the fact that the whether to vaccinate your child is not going to be a choice for a lot of people because now school systems in parts of the country are mandating vaccination. They're not, we just looked this up before the segment, it doesn't look like booster shots are being mandated. It's not inconceivable to think they might be for the kids. So that's, while I think a lot of parents vaccinating their kid would be absolutely the right thing to do, I still think it should be for the kids. Certainly, it should be the family's choice, and that's not going to be a choice, or it's going to be a more difficult choice because there are requirements also at the policymaking level.
Just to be clear, the COVID vaccine for children is not required as a condition of school attendance anywhere in the country yet. And so that's a long-term conversation. We have vaccine mandates in every state in the country, and we have since the 1960s through the last state came on board in 1981. And those mandates have been really important, not just for getting kids vaccinated, but for creating federal funding to support vaccinations and to make sure kids have access to healthcare. So our history of mandates shows that although parents have the ability to exercise exemptions in every state in the country for medical reasons and in most states for non-medical reasons, we know that those are tools that are really important to make sure that if we're going to require education, that all children who show up to school don't face increased risk because of other parents' decisions. And we have great historic examples that these exemptions have limited their usage when they're really easy to exercise, and that having mandates has been really effective in making sure high numbers of kids are vaccinated against a wide range of vaccine-preventable diseases. But the COVID vaccine right now is not among them, and that's a really important differentiation to make right now. The other thing I would add is that we know in the history of viruses that there's lots of things about infections that we don't learn until decades later. We didn't know about post-polio syndrome for decades later. We only recently learned that measles infection can wipe out your immune system and create what they call immune amnesia years and years later. we don't yet know the full ramifications of COVID infection. And, as we're watching science in real time, we're learning that there may be predispositions to long COVID. We know some children who've been infected are experiencing symptoms 6 months later. And so the bar can't just be death or hospitalization if we really want to think about what this means long-term for children's health. And that's stacked against a vaccine that has a very, very safe, strong safety record for children in general. And I think you can parse out individual subgroups like our teenage boys in a different category, although there have been no hospitalizations or deaths from myocarditis or pericarditis, and that's worth considering too.
Yeah, David, what about that idea that we don't know, the long term, we don't yet fully understand the long-term risk, and so that should be, placing the thumb on the scale of then vaccination and booster shots, again, even for children?
Yeah, there are a number of really good, interesting points brought up. And I mean, the first one is the comparison to other, the sort of MMR and the other vaccine schedules breaks down because this vaccine does not have an epidemiological benefit in the way that those and other vaccines do. We know that people who are vaccinated now, unfortunately, get infected and are able to transmit the virus. So part of the reason for vaccine mandates is that there's a societal benefit, that it's not just about the individual, but that is not the case with this vaccine. So there's something that people need to keep in mind, number one. Number two, many, many children, way north of 40%, have already been infected. Many other countries acknowledge that what's known as, natural infection, being infected counts as some degree of protective immunity. Some places count that entirely. Others view it as one dose or, one exposure. Our country is unusual in that we absolutely do not even acknowledge that if someone had prior infection, that has an impact on their immunity. And lastly, again, I can't stress this enough, the data presented in the CDC's own meeting, as well as there's a memo from the FDA based on Pfizer's own models, showed that young males it was basically a wash, the same number of hospitalizations averted as they would have of cases of myocarditis. So we have to really think through whether this is a worthwhile endeavor, certainly one that shouldn't be mandated. And the meeting, interestingly, the members of the committee spent an hour discussing whether they should use the word may or should in their recommendation. And they landed on the word should. And when we use a word like should, that ultimately leads to mandates in the end. And we've seen that with the earlier course schedules of the vaccine. So I think we're in a bit of dangerous and unethical waters when you compare the U.S. to other countries and when you think about all these factors put together.
I'm curious if either of you know if we have any data at all on what happens after you've been vaccinated, potentially vaccinated and boosted, and then you still get the virus. I mean, we do a lot of comparison about what is the rate of myocarditis if you just get infected? What is the rate of myocarditis if you get the vaccine after one dose or after two doses? I know I don't think they have a whole lot of data on after three, but I don't know if they have any data at all. Now knowing that these vaccines are not stopping the spread, so you get the vaccine, you put yourself at risk or your children at risk of myocarditis, and then what happens when they get infected on top of that? Do we have any data whatsoever on that?
I would just start by saying that we have to remember most of us have not lived through a pandemic as it's unfolding in our lifetimes. We're used to a vaccine schedule that has been set for decades, where we've had, years and years of information available. And so what I'd say is that data are expensive. They're paid for in illness, they're paid for in infection, they're paid for in human lives. And we've learned a ton in the last 2 years, and that's been really expensive knowledge. There's evidence that infection pre or post vaccination, but with vaccination actually leads to a stronger immune response. And I think, in thinking about is there a community benefit to these vaccines? We don't have great limitations on transmission for this vaccine, and there's other respiratory illnesses we vaccinate against that also don't fully limit transmission. But we do know that you have less viral shed with vaccination, so you're less contagious, even if not entirely not contagious. And I think in the next several years, we're going to learn even more about what that combination of wild virus infection plus vaccination yields in terms of long-term outcomes. It's worth noting that, when it comes to respiratory illnesses, whether whether it's pertussis or influenza. We have vaccines that are not the same as what they call sterilizing immunity. They don't create lifelong immunity the way the measles vaccine does, but that doesn't mean they don't have a role to play in thinking about transmission. And while I agree it's always worth looking at risk and benefit, I mean, I'm a parent of a teenage boy. I spent a lot of time thinking about this decision myself. We have to really think through those pros and cons, but they're always situated in a longer and larger conversation. And I'll just add that we do have vaccines on the schedule that don't have community benefit, like tetanus, for example, but that are life-saving to the individual and limit healthcare resources. And we have other vaccines that have transmissions that aren't required, but that can also have life-saving capabilities, thinking of things like the HPV vaccine that's not required in any school. Yeah. So vaccines are not all one thing, but they do have a sizable role to play, even if it's in the short run.
Yeah. David and Jennifer, thank you so much for joining us. We got to leave it there, but we really appreciate it. We'll be back with more Rising right after this.